6.560, yeah, 60. So a little bit more than the typical diffuse like enlargement of the pancreas. And I think it's not so difficult to recognize if you ever heard about it, of course.
Yeah, this is true. Yes. Thank you very much.
Thank you very much.
Thank you, dear colleagues. The next speaker is Ewa Malecka from Poland. Ewa, the stage is yours. Niech się páči.
So first of all, I wish to acknowledge Professor Peter Heggie for the very flattering invitation, and I want to congratulate you for the terrific meeting. And the title of my talk is sort of naive, but the inspiration was that many groups are working on the very sophisticated molecular biomarkers, and I am also myself a proud member of Pandora Consortium and of Federico Calzian and Daniel Campa, and there is many new biomarkers, but the clinical use, I guess we still need to wait for it. So I decided to look into something more simple. Now that was already told several times, that pancreatic is the cancer that is growing with a growing incidence, and other cancers are lowering their incidence. And it was already told that it's estimated to be the second leading cause of cancer death by 2030. We all know that only 20% of sporadic PDACs are diagnosed during a potentially resectable stage. And we know that there is no gold standard for the diagnosis, especially in the early stages. And it has particularly high incidence and mortality in high income and developed countries. Those issues were already analyzed here. There is many barriers for screening in general population because, in particular, that's relatively low incidence. So the test that we need should have high sensitivity and specificity, like 100%. Not possible? Well, we'll see. On the other hand, there is not accepted burden and false positive cases. Marco Bruno was talking about that. This is the only one cancer among the 5 most common cancer death causes where general population screening is not recommended at all, because we do not have the evidence for improved incidence and mortality rates, so the risk is higher than profit. On the other hand, screening is being recommended in high-risk groups, familial pancreatic, hereditary syndromes, history of chronic pancreatitis, multinosis, IPMN, and new onset diabetes, also being a bit controversial. So could those markers be any useful in early diagnosis? We all know that imaging techniques are not enough. We were talking about that. They do not detect early curable lesions smaller than 1 centimeter. And on top of everything, they do not differentiate chronic pancreatitis from PDAC. But for Marco Bruno, it was just one paper. I am more optimistic, and I think that there is hope if the recent surveillance study of high-risk asymptomatic individuals with germline CDKN2A mutation, there was a 75% reduction rate of resectable tumors. So this is really new and promising, resulting in 5-year survival rate of 24%, which is twice as much as in sporadic cases. So different attitude for me, it's promising. also low cost and invasiveness, low invasiveness indicated maybe those biomarkers detected in serum or some other easily available biological material should be the ideal method for PDAC early detection. As we know, we have many biomarkers. They are very sophisticated. That's even in Daniel says that maybe it will be cheap to do GWAS for everybody, but I think we generally need something cheaper. So what should be the ideal PDAC early detection biomarker? Cost effective. Julia Meyer was telling that should be less than 400 euro. I would say with our financing of medical care, I think it should be even less expensive. Should have high sensitivity and specificity, like close to 100%. Should be not invasive. Should be possible to be useful for early diagnosis, and should increase radical operation, surgery number, and survival. No, that looks very ambitious, I know. We're not talking much about CA19-9 because this is boring, I understand that. But this is the only FDA-approved PDA biomarker, and it's not that yet. The advantages and disadvantages, we know that when it's low, that doesn't say nothing. When it's very high, it's very strongly predictor of pancreatic cancer, but it's already too late. And well, we know that patients with specific Lewis genotype do not express it, so there's false negative results in some subpopulation. And also then, this is not specific at all because we can see it elevated in many other cancers and other pathologies like pancreatitis, liver cirrhosis, acute pharyngitis. We know. So for sure, it's not useful in general population screening for early pancreatic cancer. But the combination with other biomarkers is very often studied, especially in high-risk population, and that was improving their diagnostic performance. And it's even included in this guidelines for the patients with high pediatric risk, that it should be used as additional surveillance test for individuals with worrisome features in imaging in this group. And now appeared something new, which is Glypican-1, and there was a paper that was in Nature and was widely commented, and looks like some promise because this glypican from exosomes is expressed highly in pancreatic cancer, mostly in advanced. Then it's also expressed in precancerous lesion, but as you can see, the number 5 is not very big, and it's not expressed at all in healthy patients, and in benign pancreatic diseases as well. So it can differentiate benign and neoplastic. Now there is some criticism over this study. This glypican is membrane-anchored protein, and it's overexpressed in many cancers. So we don't know if this is pancreatic cancer or maybe some other cancer. And it was identified using mass spectrometry, and it was specifically enriched, and was monitored in patients with PDAC and also mice with cancer. And the results, the parameters were fantastic. AUC of 1, sensitivity 100%, specificity 100%, positive predictive value 100%. And also, it's possible to be measured with ELISA. And by the way, this compound is a target for the new therapy, mituximab, first monoclonal antibody targeting glypican-1, is already after the first trial on safety. And something as something as simple as inflammatory indices are widely available. Can it be useful? We know that chronic inflammation is accompanying carcinogenesis and early phases and during initiation, promotion, invasion, and spread. There is many inflammatory indices and immunologic ratio, including intratumoral or circulating neutrophils, platelets, lymphocytes, monocytes, counts, and they were proposed to be the biomarker for a wide range of malignancies. For example, pediatric patients manifest monocytosis at diagnosis, and this monocytosis is higher than in healthy controls. And there is also other indices like platelets to lymphocyte ratio, modified Glasgow score, which is based on albumin and CRP, and neutrophils to lymphocyte ratio. So you can see here, can I show something or not? So this is simple peripheral monocytes, and at the diagnosis is a big difference, pancreatic cancer versus control, and also this increase is starting 6 months before the diagnosis. Another one, because I have just, I'm just presenting something I'm interested in, not everything, of course. Thrombospolin, another interesting glycoprotein present in extracellular matrix, and it's inhibiting tumor angiogenesis, controls tumors grow, and it's considered to be the body's defense, to contribute to body defense anti-cancer mechanism. This glycoprotein was overexpressed in mitral squamous cell carcinoma transplant and was significantly correlated with tumor growth inhibition by more than 90%. And THPS2 level with ELISA differentiated pancreatic cancer from healthy subject with AUC of 0.87, not that great, but on the other hand, when combined with CA99, the values were much higher, and it was like 0.97 for stages 1 and 2 pediatric, 0.96, and for locally advanced and metastatic pediatric, 0.97. And this glycoprotein improved the ability of CA99 to distinguish pediatric from pancreatitis and MN, but not from pancreatic pneumonia tumors. And this combination discriminated pediatric both early and advanced from healthy donors with a high IUC. The combination of THB2 to CA99 and circulating cell-free DNA, so that was an additional marker. There was C statistic were used of high value, was also useful for early stage pediatric detection. And the mechanism was being evaluated, and it was expressed in cancer-associated fibroblasts, not in neoplastic cells, and its level gradually increased with the disease progression in genetically engineered mouse models. And there is also a suggestion that THPS2 may act as a novel therapeutic target to block the cancer stroma communication, which we all know is important. And we were being inspired with our former studies on the use of EGF and EGF binding protein ratio, useful for differentiation of pancreatic cancer and healthy subjects, and this is in this line. We are looking into apelin and serum amyloid A3, which are connected to many cancers and also to the inflammatory states and metabolics. And we have seen the apelin was higher in chronic pancreatitis as regards to control and PDAC. And on the other hand, A3 was especially high in pancreatic cancer with metastasis compared to chronic pancreatitis and controls. Of course, this is very preliminary data. We are going to look into it further, and we see it may be also used for differentiation of those diseases. About prognostic value, I'm not talking about predictive value, but there is accumulating new data on CA19-9 prognostic value. And this CA19-9 level above 100 increases the possibility that pancreatic cancer is unresectable, highly advanced, and metastatic. We all know it, but it was proven. And also may be used in evaluation of treatment efficacy, like postoperative CA19-9 decrease, and they normalize after adjuvant therapy, and this is associated with better prognosis. Low postoperative level of CA19-9 was associated with better response to gemcitabine, adjuvant therapy, and higher median survival. And this is included in ESMO guidelines. In patients with high preoperative CA19-9 level, after the operation, this marker should be monitored every 3 months for 2 years, along with abdominal CT scan every 6 months. And this is, for me, interesting study that is showing that after surgery, when you have the surveillance with CA19-9, it was observed that it is increasing before the actual recurrence is being seen in imaging techniques like CT MRI. In 60% patients after surgery, significant CA19-9 increase occurred before recurrence diagnosis in imaging techniques. Other prognostic markers, again, glypican-1 was correlated with tumor burden and survival in patients before and after tumor resection. There's also another glypican, glypican-3, highly expressed in PDAC, and that correlates with unfavorable outcome. We all know that trefoil factor 1, 2, 3, when combined with CA19-9, they are connected to short survival in PDAC. And THBS2 had also prognostic value, and where the coefficients were very high for both death by 180 days and progression by 90 days compared to the remaining patients. Also, the coagulation parameters were being evaluated, and like the dimers and fibrinogen, and the lower values were connected to longer survival after surgery. And in patients with resectable PDAC, according to CT, high the dimers suggested unresectability due to invisible metastases that were warranting diagnostic laparoscopy. And again, inflammatory indices were evaluated. PDAC patients with monocytosis at diagnosis demonstrated a decreased overall survival compared to those without monocytosis. And elevated platelets to lymphocyte ratio is associated with unfavorable overall survival in patients with PDAC. And this modified Glasgow score is also evaluated, higher values connected to shorter survival after chemotherapy and pancreatectomy. And there is data on neutrophil to lymphocyte ratio, they have prognostic benefits on survival after resection of early stage PDAC. The ratio higher than 5 is connected to shorter survival and unfavorable prognosis in advanced PDAC after chemotherapy. Low ratio, longer survival, longer disease-free survival, smaller tumor size, higher differentiation with a cutoff value 2 to 5. And also there is a study on vascular reconstruction and radical resection of advanced PDAC, which improves survival, we understand that, but higher elevated NLR was a negative predictive factor. And also there is many studies on the use of CA19 and other simple biomarkers in the decisions after PDAC diagnosis in terms of prediction of response to neoadjuvant therapy, prediction of resectability, preoperative prediction of early relapse, and postoperative prediction of early relapse. So CA19 is not there. So concluding, most societies and expert groups recommend still CA19 as the best studied PDAC marker, and its prognostic role is increasing based on the studies. New strategies are required to improve isolation and the marker specificity and sensitivity. We need those molecular biomarkers to be sort of transferred into real life that would be easy to use. Finding a single protein detecting PDAC is not likely, as we all know, due to its strong genetical heterogeneity. Combination of several markers, including both cancer and immune-related proteins, are promising. And we need large international multi-center studies, PDAC registers, multinational biobanks, strict international cooperation, and increase of PDAC awareness in the society. Those things are necessary for future progress. So we need Peter. And I would also like to express my sorrow for the Natalia Gubergridz, who won the EPC meeting organization many years ago. And always when it's happening, it's some disaster. So we are very sorry. And also I want to say that my university and many researchers, societies are protesting against the war in Ukraine. Thank you very much.
Thank you very much for the detailed systematic review of the literature.